So in this video, we're going to take a quick look, well, maybe not a quick look, but a look at pain. So pain can be described as an unpleasant sensory and emotional experience associated with tissue damage or potential tissue damage, or described in terms of tissue damage. Now that's quite a big definition of pain, and this is the definition that's used by the International Association for the Study of Pain. There are some other definitions out there, but I think this definition nicely encompasses everything that has to do truly with pain. So for example, you can see that it's an unpleasant, obviously, sensory or emotional experience. So this makes pain quite different to other types of sensory stimuli or sensory experiences, for example, such as basic touch or sight or sound or taste, in which the emotional component doesn't heavily alter the experience. But when it comes to pain, the emotional component truly does alter the experience. And we'll get to that point when we talk about descending inhibitory pathways. So now that we've got the definition out the road, let's look at pain and the pain pathway and how it all works together with the central nervous system. So I think the first thing we need to have a look at are some of the triggers for pain. So we know that we've got fine touch or two-point discrimination touch. Now this will travel to the brain via a different pathway than the pain and temperature pathway. So first thing you need to be aware of is that pain and temperature basically piggyback on one another when it comes to being sent from the external environment or internal environment to the brain. It's different to that of the simple fine touch or two-point discrimination touch. They go to the brain together through a different pathway. So what type of stimuli triggers pain? That's the next question. Well, pain can be triggered by mechanical stimuli. Pain can be triggered by thermal stimuli, so temperature, or it can be triggered by chemical stimuli. So mechanical, thermal, and chemical are the three stimuli for pain. Now, what you're going to find is that when we look at receptors for pain, so obviously you need a receptor to pick up a stimulus. For pain, these receptors are free nerve endings. So remember that your nerves are going to be myelinated. What you're going to find for pain is that the receptors are free nerve endings and they're unmyelinated. They're not encapsulated with certain types of connective tissue. They are just free nerve endings. So we can say free nerve endings. And there's basically two main types of fibres that pick up pain. And these two main types of fibres are what we call A delta fibres and C fibres. Now A delta fibres, now both are thin in diameter, so they're both thin fibres. Now when I say thin, that's a comparative term. It's thin in comparison to the fibres that send normal touch or fine touch stimulus to the brain. So these are thin fibres. They're also poorly myelinated, which means they don't have a nice sheath surrounding them. You'll find that the A delta fibres are poorly myelinated, and so are the C fibres, but they're even less so. So we could basically say that they're unmyelinated. So both are thin fibres, both are poorly myelinated or unmyelinated, and what you'll find is that A delta fibres, they send a relatively fast signal, or at least compared to C fibres, they send a fast signal, and C fibres send a slow signal. How fast? Well, around about 15 or so meters per second, and for slow, it's around about half a meter to a meter per second. Now, why do we have two different types of signals sending pain, or fibres sending pain to the brain, one that's quick, one that's slow? Well, what you'll find is that the A delta fibres, the type of signal that they send are quick, sharp, stabbing pains. And the C fibres, they send slow, dull, aching pains. Now this makes sense when you stub your toe in the middle of the night, you'll kick something, you'll first experience the first pain, which is the fast one, it's going to get to your brain faster. You experience a sharp stabbing pain, and that tends to subside relatively quickly, and then what takes over is this slow, dull, aching pain. So what I want to talk about is the fact that I'm going to show you the pathway that these two fibers take to the brain and what they do in order to alter your emotional state as well, and also result in you experiencing pain. So when it comes to these three stimuli, stimulating these two different types of fibers, what you're going to find is that even though these are the three stimuli, there's three main types of receptors. Now, you may say, yeah, mechanical, thermal, and chemical. But in actual fact, the receptors that pick up these stimuli, one is what's called a high threshold mechanical. Another one is called a mechanicothermal receptor, mechanicothermal. And another one is what we call a polymodal. So of these three stimuli, what do these receptors pick up? Well, the first one, which is a high threshold mechanical, obviously picks up a mechanical stimulus, but it's high threshold. Now, what does that mean? Well, you know, hopefully you know that when you need to send a signal through a neuron, it needs to stimulate an action potential, and an action potential needs to hit a particular threshold in order for it to occur. So for example, for most neurons, it's around about negative 55 millivolts. This is the difference, the threshold that it needs to reach before it can send an action potential. Now, higher thresholds mean that it's not going to be negative 55, it's going to be somewhere higher than that. Now, what that means is it takes more positive ions to influx to stimulate it, okay? So with normal touch, right, with normal, fine, two-point discriminative touch, such as that of being able to feel that I'm holding this pen, they're low threshold mechanical stimuli. So it doesn't take much to stimulate the mechanical receptors, because mechanical receptors require some sort of mechanical force or depression on the receptor, and this alters its conformation and lets sodium ions rush in. They're low threshold, which means that you don't need many sodium ions to come in to send the signal to my brain and I go, oh, I'm touching something, right? But when it comes to these high threshold mechanical, fine pressure or reduced amount of pressure isn't sufficient. You need a fair bit of pressure, and that's why you've got this delineation between fine touch, and then if something pushes very hard, it can be quite painful, because that's now triggering these high threshold mechanical receptors. You require more sodium influx in that area. Mechanicothermal, well, they simply pick up mechanical force and temperature, and polymodal actually picks up all three types: mechanical, thermal, and chemical. When it comes to A delta fibers and C fibers, what type of receptors do they have? Well, what you'll find is that the A delta fibers will have high threshold mechanical receptors and mechanicothermal, and that the polymodal receptors are those of C fibers. Okay, so far, what have you learnt? You've learnt that pain neurons have free nerve endings, okay, so they're not encapsulated at the end or covered in myelin. There's two main types of fibers that are connected to these receptors. They're C fibers and A delta fibers. A delta are faster for a sharp stabbing pain, and C fibers are slower for a slow, dull, aching pain. The type of stimuli that can trigger pain fibers are mechanical, thermal, and chemical, and they can trigger receptors via high threshold mechanical, mechanicothermal, and polymodal. Now what we need to talk about is draw up the spinal cord and show how pain can get to the brain differently to fine touch, and talk about some clinical implications. All right, so let's now draw up a cross-section of a spinal cord. So let's now draw up a cross-section of a spinal cord. Okay, Now, a couple of things. This is a transverse section, so we're looking in. We've got the grey matter here. We've got the central canal there. We've got white matter here. And you're going to have, obviously, your dorsal nerve root with the dorsal root ganglia and your ventral nerve root. And they come up to form a fixed nerve, as we're aware, and that's your spinal nerve. And obviously you have pairs of spinal nerves, so it's going to happen on the other side as well, but we're not going to worry about that at the moment. All right. Now, a couple of things is, first thing is that you know that the white matter, which sits out here, they're simply the highways. They just send the signals. So they're going to send signals up or they're going to send signals down. If we have a look at a spinal cord and have a look at these tracks, what you're going to find, for example, is that there's going to be white matter tracks at the back here. And these white matter tracks will send signals up to the brain. So therefore, sensory input. And these white matter tracks are here for fine touch. They're called the dorsal column. All right? They're there for fine touch, two-point discrimination, and proprioception. Okay? It's actually called the dorsal column medial lemniscus pathway. I've done another video on that, so please feel free to watch it. You're going to have pathways here that are coming down on that side and on this side. And this is going to be for motor, so it's going to send a signal out. And this is the corticospinal pathways, and this is for motor. Now, it's actually motor predominantly for the limbs, for example. And you'll find that here you've also got motor pathways at the anterior aspect, and this motor is more so for the axial. So the axial musculature, so that's going to be the thorax and the torso and so forth. And then here you're going to have, I should change the color, I think. Ascending will be in blue, descending will be in red, and you've got ascending pathways here. And this is for pain and temperature. And this is called the spinothalamic tract, and that's what we're going to focus on. So we're not going to talk about any of these descending motor pathways, so we're not going to talk about what's happening up here or down here. We're going to talk about, firstly, fine touch getting to the brain, and pain and temperature getting to the brain, and how it works differently. Okay, so these are the white matter tracks, first of all. So now let's draw it back up and talk about touch getting to the brain. So get our cross section of the spinal cord. All right, and we're going to have the dorsal nerve root, ventral nerve root coming together to form a mixed spinal nerve, dorsal root ganglion. Okay, now let's just say that this is my finger and the neuron for fine touch is coming into my arm, into the spinal nerve, which is this here, and we know that it must go through the dorsal nerve root. All sensory input goes through the dorsal nerve root. All motor comes out the ventral nerve root, so you need to know that first of all, and then it's going to come into the dorsal grey horn. All right, so let's make fine touch in blue. So something is triggered, so fine touch. Let's say it's my finger. Something has triggered that neuron and it sends an action potential in through the spinal nerve, up through the dorsal nerve root. That's the dorsal root ganglion. A ganglion is where cell bodies sit outside of the central nervous system. All right? It continues in. It goes into the spinal cord at the dorsal grey horn. And what happens with fine touch is that this neuron jumps into this dorsal white matter and it starts to move up towards the brain. So now what we need to draw is a little bit of the spinal cord, then we need to draw the brain stem and then the cerebrum. So we've got a bit of the spinal cord here and here, and now we're going to go to the medulla and then the pons and then the midbrain, and then we go into the cerebrum. Okay. So, what's going to happen? Actually, let's just draw this a little bit lower so that I can show you more so what happens at the cerebrum. Medulla, pons, midbrain, medulla, pons, midbrain, cerebrum, cerebrum. Let's draw up the thalami, which is there in the diencephalon. We'll talk about that in a second. Okay, so what's happening here? The touch signal has just come from my finger. It's going in the dorsal nerve root. It goes into the dorsal grey horn, jumps into the dorsal white matter here, goes up these tracks, continues up until it gets to the medulla. So let's label this. You've got the midbrain. You've got the pons, and you've got the medulla, and we know together that's the brainstem. This is the cerebrum, cerebral hemispheres, and these are our thalami. Okay, our thalami. We'll talk about that in a sec. So the touch signal is going up. Once it gets to the medulla, this is where it synapses with a second neuron. Now, here it synapses with a second neuron and it decussates, meaning it crosses over to the other side of the spinal cord. So that means that when you have a simple touch, fine touch, coming into my hand, for example, down my arm, into my spinal cord, it goes up to the brain the same side in which it came in. Okay? And at the medulla, which is the lowest aspect of the brainstem, that's where it synapses with a second neuron and decussates, which is the term we use for crossing over to the other side of the brainstem, and then continues to ascend and goes to the thalamus. Now, why the thalamus? Because the thalamus is the sorting center of the brain, and it takes sensory information and it decides what to do with it. It goes, okay, am I going to send it to this part of the cortex, this part of the cortex, maybe off to the limbic system, maybe somewhere else? So it's the sorting center, just like the post office. And it decides, okay, I'm going to send this signal to this part of the cortex, which is associated with the hand, for example. So what you can see is that ascending sensory information is a 3-neuron chain. For fine touch, it's 1 to the medulla, 2 to the thalamus, 3 to the cortex. Now, you're probably watching this going, I don't care, I'm here to talk about pain. Well, let's now look at the pain pathway. Let's now say that it's coming from the same finger that I had the fine touch, the tickle with the feather, for example, and now we're stimulating nociceptors. Nociceptors are the pain receptors. Remember, I spoke about those pain receptors, high threshold, mechanical, mechanico-thermal, and also the polymodal. We're now stimulating that at my finger, maybe with a pinprick. And we send a signal down, remember, the A delta and C fibers, and it's coming in. Because it's sensory, it still goes through the dorsal nerve root, goes into the dorsal grey horn, and a couple things may happen. First of all, if it's an A delta fiber, what you'll find is it'll synapse very, very early in this dorsal grey horn. So let's just say it is an A delta fiber, the fast one. It will synapse in the first two couple of layers here, these rex layers of the rexed laminar layers of the dorsal grey horn, maybe 2 or 3 or 1 or 2, and it synapses here with the second neuron. So this is different to touch already, and it will then cross over anterior to the canal into the lateral white matter, okay? This lateral white matter. And what it will then do is it starts to ascend up the spinal cord. Now it bypasses the medulla and goes straight to the thalamus where it synapses. It must go to the thalamus because all this sensory input, in order for you to be aware of it, must go through the thalamus, and then sends a signal again to the part of the cortex associated with the hand, but this time you know it's painful. So what can you see? You can see that compared to touch, the pain signal, the first, still a 3-neuron chain, right? 1, 2, 3. So all sensory ascending pathways are 3-neuron chains. The first synapses at the dorsal grey horn with the second neuron, which decussates at the level in which it entered the spinal cord, crosses over, goes into the white matter. Now, probably more so into the anterior lateral white matter, which is more so down here, and then moves upwards. And then continues to ascend, bypasses the brainstem, goes to the thalamus, synapses with the third neuron that then goes to the cerebrum and says, okay, you're now experiencing pain. This happens because it's A delta quickly, it's a sharp pain, and it goes straight to the thalamus, and it's quite localized. So A delta fibers will give you a localized, relatively specific pain. You know it's coming from your finger, for example. Okay, how is this different to a C fiber? Well, let's now just pretend that this red pathway we've drawn is now a C fiber as opposed to an A delta fiber. Okay, it's still going basically via the same pathway to the brain. Now, the A delta fibers are usually known as the neo-spinothalamic pathway. So what I want to write up now is this. The pain pathway is called the spinothalamic pathway. And now you can see why, because it goes from the spine to the thalamus, right? Spine to thalamus. The spinothalamic pathway, that's the pain pathway. And you can have the neo-spinothalamic pathway. Neo means new. Or you can have the paleo-spinothalamic pathway. Paleo is referring to old. What's the difference? Well, the neo is usually the A delta fibers. And the paleo is usually the C fibers. Okay, so if you hear the neo-spinothalamic pathway, it's that fast A delta fibers, quite specific and localized. And then the C fibers, paleo, older, it's a slower signal, and what you'll find is it's not that localized. It's more a diffuse pain. So when you stub your toe, for example, the A delta, you know exactly where you stubbed your toe, but then that dull aching pain afterwards, you just get this general ache around your foot, for example. So it's poorly localized. All right. So now this is a C fiber coming in. It's more slow, about 0.5 to 1 meter a second, right? And as it comes up, this is one of the differences. Instead of just synapsing at the thalamus and then at the cortex like the A delta fibers do, there's actually branches of C fibers that synapse with other different areas of the brain. So for example, what you're going to find is moving down your brainstem, you've got something called the reticular system, okay? Or the reticular formation. So this is the reticular formation. And the reticular formation is there, and it helps sleep-wake cycles. So basically it's there to tell you whether you're awake or asleep, okay? Basically, it's a system that when you're asleep, it's suppressed, and when you're awake, it's activated. And what's going to happen is that as this C fiber comes up, it's going to send branches off and synapse with the reticular system. That means that when you have a C fiber activated, stimulating the reticular system, you end up being awake. One of the reasons why you can't sleep when you're in pain, because it's activated the reticular system. Another thing that it activates as it comes up is the limbic system. And so the limbic system is going to be involved in emotion. So you're going to have signals coming off sent to the limbic system, for example. And the limbic system allows you to have some sort of emotive connection to it, okay? Are you going to be happy? Are you going to cry? Are you going to get depressed? What is the association with it? Now, a couple of other important points. I want to talk about the fact that you can modulate pain at different levels. So for example, anytime you talk about modulating pain, we're talking about changing pain, changing the perception, because pain is 100% at the level of perception. Now you may say that's not true because it's stimulated here, synapses here, synapses here, synapses here. So it's not just at the level of perception, but it actually is, because different to other types of sensory input. For example, you know that a particular wavelength of light will result in a particular perception in the brain. Color perception. you know that a particular decibel will result in a particular sound perception in the brain. But when it comes to pain, you cannot adequately tell me that a certain stimulus here is going to result in somebody experiencing a certain type of pain. You can't be sure. The way I experience it is going to be different to the way the next person experiences it. I may say it's a 9 out of 10, the next person may say it's a 2 out of 10, and you've stimulated them the exact same way. And the reason why is because pain is modulated or changed here peripherally, here centrally, or here centrally. Okay? So how is it modulated? All right. Well, it's modulated a number of different ways. Firstly, let's just talk about, we haven't spoken about any of the neurotransmitters, we haven't spoken about any of the other chemicals or anything like that, so let's do that. Some of the chemicals that are released that stimulate pain and pain receptors include glutamate. Now, glutamate is the main neurotransmitter for pain. Substance P. And then there's other chemicals that can modulate pain, and the way it modulates pain is often it reduces the threshold. So if you've got certain chemicals released here or here, for example, what it can do is it can drop the threshold, which means it makes it a lot easier to send a pain signal. And these types of chemicals include potassium, it includes bradykinin, it includes prostaglandins, many different other chemicals, cytokines. I mean, I could probably list another 50 of them. So many different chemicals. Now, you may see that prostaglandins, bradykinins, for example, cytokines, histamine, these are all others, tick, tick, these are associated with inflammation. And this is important because there is a link between inflammation and pain. And that's probably not a surprise to you because all inflammation is, okay, so inflammation is a response to injury to vascularized tissue. So anytime vascularized tissue is damaged, so this is tissue with a blood supply, you'll get an inflammatory response. This means that avascular tissue such as cartilage will not elicit an inflammatory response, and is one of the reasons why it takes so long for cartilage to heal itself when it's damaged. Okay, so these are all different chemicals, so neurotransmitters, for example, and various chemicals that can modulate pain. They can either stimulate pain receptors or they can reduce the threshold to make it easier to send pain. So for example, if here peripherally, let's just say somebody cut my hand, or keep with the finger, somebody cut my finger, that's going to be damage to vascularized tissue and result in inflammation. Inflammation results in the release of histamine and bradykinins and prostaglandins, and what they do is they can stimulate pain receptors and they can drop the threshold and make it easier to send a painful stimulus. And it goes in, and the same thing happens here. You also have the release of these chemicals centrally in the spinal cord, okay? Which means it makes it easy to send the signal at the spinal cord level and going up and so forth. Now, you've probably noticed that if you've fallen over, or you see a little kid, or you remember being a little kid falling over and you rub the wound, you knock your head, you rub that to make it feel better. How come rubbing some injured site makes you feel better? This is something called the pain gate theory, okay? How does the pain gate theory work? Well, what I'm going to do is I'm going to wipe this off for a second, and I'm going to show you a more zoomed in picture of the spinal cord and tell you how the pain gate theory is proposed to work. Now, the pain gate theory was proposed in the 40s and 50s, and basically what it states, pain gate, the gate is there because it says that you can basically gate off or limit a painful stimulus through other sorts of sensory stimulation. So if you have the spinal cord, so you have the spinal cord, okay, so you've got the spinal cord, and what's going to happen is painful stimulus coming in. Dorsal root ganglion, so that's the cell body of the pain neuron. It's coming in. Synapse is here, the second neuron, which crosses over, goes up. Not a surprise. Now, touch signals coming in. And remember I said the touch signal will jump into the dorsal column and go up the opposing side, right? What you'll find is that from this primary afferent sensory neuron that's going to the brain via the dorsal column, you have some branches that come off at the dorsal grey horn. And they will synapse with another neuron, which is an in-between neuron called an interneuron. Now I've even drawn it too small there, so let's just draw it over here. We've got the pain neuron synapsing with the next pain neuron, which is going over and then going up. And then we've got the sensory neuron coming in, going up, but you've got a branch that comes off, synapsing with what we call an interneuron. And as you can see, this interneuron synapses with the secondary nociceptive neuron, the secondary pain fiber. What's happening here is that when you get a painful stimulus, positive, pain, touch, well, if you get a painful stimulus, let's just say you knock your head, right? Painful stimulus coming and going to the brain. Now let's just say you rub your head, rub. What you're doing is stimulating these blue fibres, the fine touch fibres. And as it comes in, this branch synapses with the interneuron and sends a negative signal, an inhibitory signal, to the pain neuron and closes the gate on that pain signal so it can no longer get to the brain. And so all that's getting to the brain is this constant touch signal that you're amplifying. So basically, the analogy that you can use, since it's pain gate theory, is that there is a gate and there's only enough room for a certain amount of stimuli to go through. If you bombard it with fine touch, then the gate is closing on pain and pain will not get to the brain. This is the proposed mechanism by which TENS machines work. So these are the electrostimulatory machines, acupuncture, massage therapy, and other alternative therapies that seem to modulate pain. But again, the evidence is limited to the use of a number of these types of alternative pain modulating therapies. So that's the pain gate theory. Okay, next thing I want to talk about is even though I showed you that fine touch and pain go up to the brain via different pathways, I didn't tell you about what the implications are of this. The clinical implications. I said I was going to tell you, so let's have a look. We'll be drawing up a lot of cross sections of the spinal cord in this lecture. Spinal cord, medulla, midbrain, medulla, pons, midbrain, medulla, pons, midbrain, cerebellum, thalamus. Okay. Touch. You know it off by heart now. It's coming in, it's going up, synapsing at the medulla, crosses over, goes up to the thalamus, synapses, goes to the part of the brain dedicated to the hand. Let's do pain. Pain comes in. Synapses at the dorsal grey horn. Decussates at the level in which it comes in, goes up the anterior lateral spinothalamic pathway, synapses at the thalamus, and then projects to the brain as well. All right, you see it's going up different sides. What is the clinical implication of this? Now, there is something called Brown-sequard syndrome. Brown-sequard syndrome. Some people may be in a car accident, for example, and they may experience damage to the spinal cord, but only one side of the spinal cord. This is called a hemilesion, which is damage on one side. Okay? So let's just say somebody experienced a hemilesion on this side of the spinal cord. What does that mean? So let's just say this is the left side, this is the right side. Let's say somebody experienced a hemilesion, let's just say somewhere at the thoracic 5 level, okay, on the left-hand side. What does that mean for touch coming from the right-hand side of the body? So the lesion is on the left-hand side. What happens to touch that's coming from the right-hand side of the body below the level of the lesion? So let's say touch to the foot or leg. Well, let's have a look. The touch is going to come in, enter the spinal cord and go up the same side it came in, which means the right-hand side, and get to the brain unimpeded, which means for touch below the level of injury on the contralateral side, which is the opposing side, you can still feel touch. What about pain on the contralateral side? Well, pain's coming in from the foot, goes into the dorsal grey horn, synapses, crosses over, so decussates at the level and tries to ascend to the brain, but it is impeded by this lesion, which means you do not feel pain on the contralateral side below the level of injury. What about a signal coming in from this side? Well, let's have our spinal nerves. Touch is coming in, goes up the same side, impeded. So touch on the ipsilateral, meaning the same side of the injury, below the level of injury, will not get to the brain. And pain, therefore, synapses, crosses over, ascends unimpeded. Pain on the ipsilateral side, the same side of the lesion, but below the level of injury, will get to the brain. Can you see these differences now? So this is called Brown-sequard syndrome, and you can test these. Remember, the pain pathway and the temperature pathway piggyback on one another. So what you can do is if somebody's come in after a car accident, for example, and you want to determine whether there is a spinal cord injury and at what level, you can get an ice cube, for example, run it up the leg so you can start to ascend up particular limbs, ascend up and ask them if they're feeling the temperature, right? So if they're feeling the temperature on this side, on the right-hand side of the body at the leg, for example, it means that the right-hand side of the spinal cord has not necessarily been damaged, right? But if they can feel that pain, but they can't feel touch, then what it may mean is that there is a lesion potentially on the same side of the spinal cord, okay? So that's called Brown-sequard syndrome, clinically very important. All right, let's move on. So what I want to talk about now is how we can modulate pain through what we call the endogenous opioid system. So you know that we produce our own analgesia. So this is medications that can mitigate pain, okay? So let's just define some terms first, actually. So you've got analgesia, which is pain. You've got analgesia, which is no pain. You've got allodynia, which is pain when there shouldn't be pain. There is hyperalgesia. Hyperalgesia is increased response to pain. and hypoalgesia, which is decreased response to pain. Okay? So, allodynia is if I were to poke you. Now, poking may be annoying, but it's not painful. But if it were to elicit pain, and it shouldn't be, right? That's allodynia. So, when do you get allodynia? You get a sunburn, for example. Have you ever had a sunburn and then you've touched it and you go, oh, that hurts, and it shouldn't. That's allodynia. Hyperalgesia is if I were to pinch you and it hurts a little bit, but then the next day I were to pinch you to the same degree, using the same amount of force, and you go, oh my God, that's so painful now. Well, that's hyperalgesia. You're experiencing even more pain. So what I want to talk about is that our body has an endogenous, that means coming from within, analgesic system. This is called the descending inhibitory pathway. Let's have a look at it. So draw up more of that spinal cord. Let's just draw it coming up like this, medulla, pons, midbrain, medulla, pons, midbrain, cerebrum, thalami. Let's have the reticular formation, which I said was, stimulating you being awake. And now let's send a pain signal in. Got a pain signal coming in, synapses, decussates, ascends, thalamus, cortex, right? Now, remember I said if it's a C fibre, you're going to get all these afferents coming off and stimulating the reticular system, but there's also something at the midbrain. I'll just draw it like this, and that's going to be called the periaqueductal grey matter. Let's draw it a bit differently. Okay, this is called the periaqueductal grey matter, which we sometimes just refer to as PAG. Okay, periaqueductal grey matter next to the cerebral ventricles, right? Periaqueductal near the aqueducts, so cerebral aqueducts. What do? As the pain signal comes in, obviously reticular system, you're awake. It also triggers the periaqueductal grey matter. Now the periaqueductal grey matter, they control a descending pathway that comes down. I'm going to draw this descending pathway in purple. So it sends signals down, right? Now, what do these signals do? Well, these signals, these descending signals, the neurotransmitter, so PAG, the neurotransmitters that are used here are serotonin and noradrenaline. Now, if you're American, that's norepinephrine. These are the neurotransmitters used for this descending pathway. And what happens is when they get down to the spinal cord, for example, they release certain opioids. What are opioids? Okay, opioids are these chemicals that are released that can reduce or mitigate pain. The opioids, they include endorphins. I'm sure you've heard of that, an endorphin release. It includes the enkephalins and includes the dynorphins. Endorphins, enkephalins, dynorphins, what they do is they're released and they trigger opioid receptors. And these receptors can be, they're called mu receptors, delta receptors, kappa receptors, right? There's many different types of opioid receptors which are stimulated by these endorphins, enkephalins, and dynorphins. The neurotransmitter that regulates their release is serotonin and noradrenaline, right? And what they do is they will inhibit pain signals being sent. They can do this peripherally. So they can do this here. Opioids can act here peripherally. They can act here centrally. They can act up here in different areas, right, as well, and they can act in the cortex. So the opioids can act all throughout the system, and what they do is they reduce the stimulus of pain being sent. How do they do this? Well, if you've got a painful stimulus, it's going to release certain chemicals here, and I said those chemicals are going to be glutamate, it's going to be substance P, prostaglandins, you know, a whole bunch of other stuff, right? And they need to be released and they need to bind to receptors here. Opioids stop that binding. What they also do is they stop the release, okay? So they stop the release of the neurotransmitters for pain, and they stop the binding of those neurotransmitters that may be available to the postsynaptic neuron. This is how these opioids work. Now, the opiates, which are predominantly exogenous compounds that mimic these endogenous opioids, they include things like morphine. And basically what they do is they mimic this activity, which means morphine can act peripherally and it can act centrally. And again, what it does is it stops the release of the neurotransmitters for pain and the binding and sending of the signal for the neurotransmitters of pain. They can do this peripherally, they can do it centrally. Okay. Now, morphine, obviously, there's numerous side effects, one of which is respiratory depression. So, what that means is if you give somebody morphine, it can reduce their respiratory rate. How does it do this? Well, we know that the midbrain and the pons controls respiration. So there's parts in the midbrain and pons here that control the respiratory process, and they respond to increases in carbon dioxide, right? So they're sensitive to increases in CO2. When your CO2 increases, it triggers these areas, for example, in the midbrain, and you take a breath. What morphine does is it makes these areas less sensitive to CO2, which means they're not as responsive to increases in CO2, and therefore the respiratory rate can be depressed, or respiration in itself can be depressed. That's one of the things of morphine. Morphine also slows down the GIT, for example, so it can result in constipation as well. All right. Okay, so what else? What other types of drugs and medications can we use? Well, the first thing we need to talk about as well, before we move on to other types of meds, is that you can have what's called acute pain and chronic pain. Now, acute pain is pain that lasts less than 3 months. So acute is simply a time frame, right? Chronic is also a time frame. Chronic pain is greater than 3 months. This is usually, right? This is just an arbitrary value that we've been putting out. But chronic doesn't mean bad, acute doesn't mean good, or vice versa. They're simply time frames. Acute for pain is less than 3 months, chronic for pain is greater than 3 months. So what you'll find is that acute usually leads to chronic when it comes to pain. How does this occur? Well, if the acute goes unmanaged, it can lead to chronic pain. Now, acute pain is also often termed nociceptive pain, while chronic pain is often termed neuropathic. Now, there's exceptions to this, but don't stress about that. Nociceptive pain is usually pain that occurs because some tissue has been damaged or is potentially being damaged, and you're experiencing pain as a means to first recognize what's happening and hopefully try and avoid whatever action that you're performing so that that pain no longer occurs. So that may be stop stabbing yourself with a pin, or that may be stop touching the hot plate, or it may be that you've cut yourself and that finger starts to hurt and it's telling you this finger hurts, maybe don't use it for a while I heal myself. Okay? So if you do all these things, then should within 3 months, this acute nociceptive pain should diminish and disappear. But what can happen is this. Pain is different to the other types of sensory input, such as sight, smell, touch, sound, and so forth. It's different in the sense that those stimuli you can become desensitized to. So let's think of basic touch. You wake up in the morning, you put your socks on, you feel your socks for about 3 to 5 seconds, and then you forget about the feeling of the socks for the rest of the day. That's a desensitization. You walk into a room, you smell somebody's perfume, after a couple of minutes you don't smell it anymore, you're desensitized, that's gone into the background. Same happens with sounds and visions and all those types of things. Pain is different. When you experience a small amount of pain, that system has evolved to amplify that pain. Pain doesn't, so this is a good point because you should not just tough your way through pain. If you experience pain, you need to find a way to mitigate that pain. Okay? Now, usually it's as simple as avoiding using the injured limb, for example, until it's healed and disappears. But if, for example, you don't let that heal, you don't let the pain disappear, what happens is it gets amplified and gets amplified at every single level. Here peripherally and here centrally. How does it get amplified? Well, a couple of different things happen. First thing is I spoke about inflammation, right? So acute nociceptive pain is usually associated with inflammation. So let's actually write that down. So the acute nociceptive pain is associated with inflammation, which means it's stimulated by those prostaglandins, histamine, bradykinins, for example. And when they're released, like I said, they reduce the threshold of pain neurons, of nociception. Reduce threshold of pain signals. Okay, so it makes it easier to send a pain signal. Now this can happen here in the spinal cord, for example, and what that means is all these chemicals, so you get some sort of painful stimulus, it sends it here and more chemicals are released here, which means that this pain neuron, the threshold's dropped, and you don't even need to trigger this peripheral fiber very much at all to result in the same amount of pain. And ultimately what can happen is no painful stimulus is being triggered here, and you're still getting a painful stimulus here. So you begin to get this hyperalgesia, and then sometimes you can get this allodynia, in which you're getting pain stimuli being sent through the spinal cord, and there's actually no painful stimulus in the periphery that's sending it through. Now this is called central sensitization. Central sensitization. And central sensitization results in decreased threshold, and you actually get the neurons changing a little bit, okay, in the sense that they increase the amount of pain receptors. So you've got the threshold decreasing, so easier to send a signal, and more pain receptors, which means it doesn't take much to stimulate them to send a signal either. Now this can happen, and over time it becomes a chronic state, right? And because these neurons have changed so much, that's what we term the neuropathic pain, which is usually changes of neurons or damage to neurons that result in chronic stimulation of pain receptors, resulting in chronic pain. Now, nociceptive pain was an indication that something's wrong, and if you fix the underlying cause, you fix the pain. Chronic pain, there's no underlying cause triggering it, so there's nothing you can do to mitigate it to stop that pain, which means you've got to try and find the best way to not cope with that pain, but try and reduce the painful stimulus some way or another. So first of all, if it's inflammatory nociceptive pain, prostaglandins, histamine, bradykinins, what you can do is take certain types of drugs that are called NSAIDs. Now, what NSAIDs will do, so these are usually the first line of pain medication in acute nociceptive inflammatory based pain. NSAIDs include aspirin, include ibuprofen, include celecoxib, and people say yes, people say no, acetaminophen, okay, which is paracetamol. So I'm going to put it in, and I'm going to get people saying acetaminophen isn't an NSAID. Well, I'm just going to put it in anyway. So aspirin, ibuprofen, celecoxib, acetaminophen, the NSAIDs. Now what they do is there are enzymes called COX, COX-1, COX-2, and they produce prostaglandins. Prostaglandins reduce the threshold of painful stimulus and sometimes can trigger a painful stimulus. So they produce prostaglandins, which means aspirin, ibuprofen, celecoxib, acetaminophen, they block COX-1 or COX-2 or both, which means they block prostaglandins, which means they reduce inflammatory-based pain. So when you have an inflammatory response, prostaglandins are reduced, causing pain. You take NSAIDs, stops prostaglandins, stops pain. Okay? This is what you can take in the acute nociceptive pain resulting from inflammation. But what happens if it's moved on to a more chronic pain? Well, NSAIDs don't necessarily work very well because it's no longer caused by inflammation. So we need other types of pain relief medications. So you can take the opioids, for example, which include the morphines and the fentanyls and so forth. But again, they don't necessarily have a great effect for chronic pain for many different reasons. One of which is that even though the opiates can block pain transmission, right, centrally and peripherally, it doesn't necessarily work that well, and you don't want to use them long term. That's the thing. Morphine, for example, because of their addictive properties, morphine is usually used, right, for acute, so short-term, intense pain, or let's say severe pain. So acute, severe pain, right? There's an E on the end of severe. Acute, severe pain. That's what morphine's used for. So that means what? 3 to 5 days-ish, maybe, right? Obviously variable. It's not used for chronic pain because of its addictive properties, and it doesn't necessarily work that well because of negative feedback. Because these mimic your own endogenous opioid system, there's a negative feedback system which tells them not to be released, and therefore you have a negative homeostatic response. So what medications can we then use for chronic pain? Well, what we find now, more and more so, the types of medications that we are using now for chronic pain include the antidepressants, and include the anticonvulsants. So anti-epileptic drugs and antidepressants. A couple of different types of antidepressants that are used. Tricyclic antidepressants, right? Cyclic. I'm a horrible speller. Tricyclic antidepressants. And also the serotonin specific reuptake inhibitors, which are known as SSRIs, or serotonin, noradrenaline reuptake inhibitors, which are called the SNRIs. Now, these are all antidepressants that are used. Now, remember here I said that for the descending opioid system that's coming from the PAG, periaqueductal grey matter, also the Rafe nucleus as well, which the Rafe magnus, which I didn't talk about, but there as well. There's many different structures involved. That the neurotransmitter involved for this descending inhibitory pathway for the endogenous opioid system was serotonin and noradrenaline. Which means that when they are released, so think about it, they're the neurotransmitters, which means when you've got a signal being sent, right, neurotransmitters need to cross that synapse. So if you've got serotonin and noradrenaline, let's write S and N, they need to cross that gap and bind to serotonin and noradrenaline receptors on the postsynaptic neuron to send the rest of the signal. Now, these serotonin-specific reuptake inhibitors, what does that mean? Well, there are mechanisms that will take serotonin that's been released into the synapse and throw it back into the presynaptic neuron. There are reuptake mechanisms that take noradrenaline, throw it back, which means that these reuptake mechanisms, not these ones, but reuptake mechanisms themselves, recycle the neurotransmitters, and they do not spend a very long period of time in this synapse, very short period of time. So if you inhibit this reuptake, what are you doing? You're keeping them in the synapse for a longer period of time, increasing their likelihood to send an action potential via the second neuron, right? And increasing the release of the endogenous opiates, which are the endorphins, enkephalins, and dynorphins. All right, so that's what the serotonin-specific and serotonin noradrenaline reuptake inhibitors do. They can also actually, apart from inhibit the reuptake, they can actually block sodium channels on the postsynaptic neuron. Why is that important? Well, we know when we need to send an action potential down a neuron, that positive sodium ions need to jump into the neuron to depolarize it. That's how all signals are sent, right? It's a depolarizing event. Positive sodium jumps into the cell. That's all a signal is. If you block that, you block a signal, right? So that's another way of how now they're not doing it on the neuron that's sending the endogenous opiate, they do it at the pain signal. So they block the sodium channels at the pain neuron, okay? So that's how these SSRIs, SNRIs work. The tricyclic antidepressants, they also play around with serotonin, noradrenaline as well, and they can also block sodium channels, and they can also block calcium channels too. So they block serotonin reuptake, noradrenaline reuptake, they can block sodium channels, and they can block calcium channels. Why calcium channels? Well, calcium channels, we know that once an action potential has reached the end of a neuron, calcium needs to enter at the end of the neuron because calcium is the trigger to release neurotransmitters. So if you block calcium, voltage-gated calcium channels at the pain neurons, you're blocking the release of neurotransmitters associated with sending a pain signal. Okay, so that's again one of the ways that these tricyclic antidepressants work. So they're the antidepressants. You've also got the anticonvulsants, and probably the only one I'll talk about is gabapentin. And gabapentin works that exact same way, calcium channel blocker. Right? It's a calcium channel blocker, which again means it's blocking calcium entering, which inhibits the release of the neurotransmitters for pain. Okay? So these seem to be the most prominent pain meds for chronic pain. So what are the types of pain meds you can have? You can have non-steroidal anti-inflammatory drugs. They're the NSAIDs. So that's the aspirin, the ibuprofen, the celecoxib, the acetaminophen. They block the prostaglandins and blocking inflammatory pain. That happens both peripherally and centrally. You can then have the opioids. So this includes morphine and fentanyl. And they mimic the endogenous opiate system of endorphins, enkephalins, and endorphins, enkephalins, and dynorphins. And what they do is they block pain transmission, and they can also alter what's happening up here in the brain centrally, alter the perception of pain too, but that's more difficult to discuss. And then for chronic pain, you can have the antidepressants, which predominantly work by inhibiting the reuptake of serotonin, noradrenaline, and also the anticonvulsants like gabapentin, which block calcium channel, voltage-gated calcium channels, which stop the pain receptors releasing the pain neurotransmitters, such as substance P and glutamate, for example. So we've gone through a lot here with pain. There's obviously a lot more that we could talk about, but maybe I'll just finish it here. If you have any questions, please feel free to send it through. But that is a quick run through of pain, pain pathways, analgesics, NSAIDs, opioids, and chronic pain relief medications. Thanks.